Welcome, everyone. My name is Joan Nagelkirk, and I'm the McKenzie Foundation Chairperson. I'll be serving as the moderator for today's event. We're holding these events for you, our friends and our supporters of McKenzie, and we're so glad to have you with us. We're going to begin today by allowing our panelists to introduce themselves, and we'll start out with Steve Barnett. Steve?
Thank you, Joan. I appreciate the opportunity and looking forward to this town hall meeting like we have looked forward to so many others. I think this has been a great venue going forward, and I have to thank the extraordinary work that our McKenzie Foundation has been putting forward, both leadership as well as all the committee members, and then of course those in the background like Nina and Gloria, who make all the technology work for us. So without them, we would not be in a position that we're in today, where we've been able to accelerate some of the investments that we've been able to make. And we're going to talk about one of those today. I generally like to speak a little bit on the front end about COVID because I think it's still on everyone's minds in the community. And so I wanted to give you a little bit of an update. We are seeing in Sanilac County an increase in the number of cases, but the good news is we're not seeing that increase rise to a level that's disturbing, particularly when you compare it to other counties throughout the state. So we've been able to keep that number, the number of positive cases in the county down relative to other counties in the state because of all the efforts that everyone has been putting forward. People are being pretty good about wearing their masks and practicing some physical distancing from others, not gathering, and then of course washing hands. And these are the measures that are going to help us keep this under control going forward, particularly as we enter the flu season. We've had some great opportunities to work with all the superintendents across Sanilac County and helping them understand and even work with parents, having Dr. Hammond as medical director over public health, get in front of parents and help them understand what some of those precautions that can be taken and why they're important. And so I think all of that effort has been working positively for us, and we continue to do fairly well. We have almost conducted 1,000 tests at McKenzie over the last 7 months, I guess now. And we will continue to be able to do testing. We're working with Bryant at Public Health and Todd Hillman with the Emergency Operations Director, along with Sanilac Transportation, to find a place where we can probably continue doing the testing that we've been doing so that we can meet the needs of the citizens of the community in a little bit warmer space, given the fact that we're beginning to get near winter, and I don't think anybody wants to be outside doing testing in the winter if we can find a better way to do that. So having said all that, we continue to keep investing in analyzers and doing the testing locally that we can do for COVID. But this is October, and we're here to talk about women's health, and in particular, breast cancer awareness. And we have a couple of individuals that are going to be working and providing you with information today that I couldn't be more proud of. The next speaker is Jay Smith. He's a director of our imaging services, and he's the guy that really makes all of this work along with the staff that he has, and really guides us in what instruments to invest in, so that again we're bringing the best technology forward and bringing it to all of you who are in this county. And then of course, following Jay, one of our nurse practitioners, Suzette Walker, is going to provide you with some great insight. And I'd be remiss if I didn't point out that again, Suzette and Brandy will be doing that road show that they did a couple of years ago, which seems to be interesting for everyone, entitled What Your Mama Didn't Tell You. And although as a male, I've never entered into that space to listen to it because I'm sure I don't want to hear some of the questions, but I hear it's very entertaining. So having said all that, I'd like to hand it over to Jay. Jay, why don't you go ahead and describe our imaging technology?
Okay, thank you, Steve. And we're very happy to say here at McKenzie, a little over a year ago, we needed to upgrade our mammography services. And the next logical step was to go to the 3D mammography, which is pretty much become the standard of care for mammography. And so as we're looking at that, we wanted something to set us apart from the rest of the field, say, that offered mammography, and also what was, say, limiting factors for being in a rural area for our patients. So in addition to the 3D mammography, we got the state-of-the-art equipment. Also, we looked at and spoke to the radiologist, like, what is going to make this so much different from other mammography studies you read currently? And that's what they said. The number one factor was you are going from a standard 2D mammogram. You have approximately 4 images on a standard patient to read. And with 3D, you're going to have like 300 to 400 images, like slices, thin slices going through the breast tissue to look at. So with that much data for the radiologist to look at and make sure that they don't miss anything, there was a new technology for computer-aided diagnosis where an artificial intelligence program in the computer will analyze each image also for the radiologist, and it will highlight any suspicious areas that it recognizes in its database as being abnormalities. And also, not only that, this artificial intelligence program assigns a score to that area to tell the radiologist, like, this is highly suspicious, or it's low suspicious for abnormality, for malignancy, and also it will also assign an overall score to that patient's mammogram study, so that the radiologist can just have more confidence in feeling that they're not missing anything for that patient's diagnosis. So, and then this artificial intelligence program, it's like other smart learning programs. Throughout the years, as studies are being put into the program, it will learn from its prior mistakes. So any areas that it previously labeled as abnormal in the past, those same areas, the database would be updated, and it would say, well, from history, and proven by biopsy, this was not an abnormal or a malignancy. So really, it as we use it and as the program grows, it will become smarter and smarter and help make a more accurate diagnosis for the women and men, and also hopefully should prevent any unnecessary biopsies or additional testing on those patients. And also another thing that McKenzie was able to invest in with the gracious help of the foundation is that we have the capabilities of performing contrast enhanced mammography on our unit, which involved having additional software and hardware on the unit that most 3D mammography units are not capable of. And the contrast enhanced spectral mammography is a study where the patient is injected in the vein in their arm with the same type of contrast used for CT studies, and after about a 3 to 5 minute wait, the patient just has a standard mammogram, and those images are taken on that mammography unit. And if there's any malignancies, those malignancies will highlight with that contrast and be outlined. So the one thing that's good, say that in our area is that we're, again, in a rural area, that normally those patients would have to go for a MRI of the breast, which is not available locally. And also the MRI of the breast is, it can be difficult to get approval from your insurance. And also it's a much longer procedure and more costly procedure than a contrast enhanced mammography. So that's what, between the artificial intelligence overread software that McKenzie has, and also the contrast enhanced mammography capabilities, really sets us apart, I would say, for the services available here. What we were finding too is after initially when we first implemented the 3D mammography, it was kind of expected. We had some good points was that patients that had previously always was having to come back for additional imaging because there was suspicious areas on their 2D mammogram. Those patients, they said this was when they had the 3D last year, they did not have to return because the radiologist was able to so clearly see those suspicious areas. And also with that overread that assigned a probability of malignancy to those areas, it gave them confidence enough not to have the patient have to return for additional diagnostic studies. And those patients, like I said, were extremely happy about this. There was patients, though, too, that on previous 2D studies, there was areas that were not seen, not even seen, that were demonstrated on the 3D, and those patients, had to come back for additional studies. But the good thing about that is now that we've had a year, those same patients that are returning this year, the radiologist can look at and say, oh, these areas were there last year and no change, everything's good. And so, like I said, that's one thing that we are seeing noticeably is that the diagnostic studies are decreasing because the standard screening 3D is showing the radiologist everything they need in one look. So that is a very positive thing for the patients, and especially for their comfort levels about worrying about if there was something suspicious going on or not. So and also another thing that we're hearing from our patients is even though the mammography unit appears similar to previous units that we've had, or the patients are saying that this unit is much more comfortable and less painful, and they said it seems like a quicker exam time. Another thing that the patients do not have to hold their breath during the imaging, which maybe if they're not holding their breath, they're not tensing up as much. So, but all the way around, the technologists are stated right from the beginning that the patients are just extremely happy, saying that this is like the easiest mammograms they've ever had performed on them. So that's another plus that, like I said, the technologists are saying that the patients are very, very appreciative of this new equipment. So, but like I said, both of those additional features that McKenzie invested in added a significant cost to the equipment, which, like I said, through the fundraising efforts of the foundation, helped enabled us to get us to this point, which, like I said, sets us apart with what we can offer here for the the advanced imaging for women's health. So I think that covers everything that I have. So Suzette, if you'd like to take it from here.
Thanks, Jay. I wanted to start with talking about numbers for a moment. Breast cancer is the most common cancer diagnosis in women in the United States. In 2020, this year alone, it's estimated that there'll be 325,000 women diagnosed with breast cancer, and 42,000 women will die from breast cancer. Let's look at that number of 325,000 for a minute. If we took the total population of Port Huron, Saginaw, Bay City, Flint, Lansing, and Sandusky, that's still a little bit under the 325,000. So that number is huge on its own. So we really need to pay a lot of attention to breast cancer. It does get a lot of press, and there's a reason for that. People are diagnosed with this, and people die from this. Women die from this. It is the third leading cause of cancer death overall. Underneath lung cancer is number 1, colon cancer is number 2, breast cancer is number 3. But if you look at women alone, it's second leading cause of cancer death, second only to lung cancer. 1 out of 8 women will be diagnosed with breast cancer within their life, and 1 out of 36 women will die from breast cancer. So when you're at a family dinner or sitting with friends around the table or at church or wherever you are, and you look around that room, your friends and your family are going to have breast cancer, and some of them will die from that. So we really need to be very gung-ho on preventative. We want to really concentrate on preventing this disease and on diagnosis in it very early. And one of the things I can tell you about early detection is that if we're able to diagnose a woman with the localized disease, they have a 99% of a 5-year survival rate. Localized disease means cure. It means the woman is going to survive the treatment and go on with her life, have follow-ups, but they are going to be cured from this disease. The sad thing about this is that only 64% of women are diagnosed with localized disease. So why is that? It's screening. Women don't go for screening, or they're not having as high-tech a screening as we have available to us. If you can convince a woman that it's not going to hurt, and it doesn't really hurt. I'm 62 and I've had lots of mammograms, and I can say I don't find that there's any pain with it at all. But if you can convince women to go and we can find these cancers early, we can cure them. If we don't find them early, then we're not going to be able to cure them, and a great deal of them will die from this disease. So I just can't stress enough how important screening is. And I think that as community people and medical people, that we need to be talking to our friends and family about this. Screening really should start at the age of 40. Some organizations will say if there's suspicion that you can start a little bit earlier than that, but 40 is the recommended age for screening. Of course, if you're BRCA1 or BRCA2, which means that you have a gene that predisposes you to breast cancer, we're talking about a whole completely different game here, and you really need to be talking to your provider about when you should be starting screening. But routinely, 40 years old is the age. Almost all insurances will pay for it at the age of 40. A few will pay for one scan between the age of 35 and 40. And if you know that that's available on your insurance, I would certainly help you to go ahead and have that done. I do want to address something that Jay said that is really very important. He talked about the ability to inject contrast during a mammogram if there's a suspicious reason or lesion that is seen. And the reason that that is so important is that breast cancer develops its own blood supply. All cancer, they make angiotensin, which reaches out and calls other blood supply from other areas to make their own veins and arteries to go to that tumor. So when when there's a contrast that can be injected, it's going to look like a pooling. They're going to be able to see that the blood is going to that area. So that really enhances the ability of the unit that we have here at McKenzie to pick up those early breast cancers and get them diagnosed before they become metastatic in any way. So I think that at this time we really should open it up to questions that anybody in the audience might have.
Okay, that's perfect timing, Suzette. And I think we will open it to questions now. And if you use the Q&A function at the bottom of your screen, all our audience members, it'll come up on my screen then and I can read your questions. So the Q&A function at the bottom, just click on that and you can ask some questions. I do have a couple of questions here. And the first one is for Jay. Jay, how long will the mammogram appointment take?
Right now, between the registration portion and then coming back for the actual exam, the patient should expect to be here maybe 30 minutes maximum. Because actually the exam, once the technologist gets the person in the room, it's done within 10 minutes, say by the time the person changes and fills out their questionnaire. And then it has the images. The images only take not even 5 minutes for the entire study. So it's very quick. And like I said, the paperwork will take longer than the exam. But yeah, so it should be within a half hour, the patient will be in and out of here.
I can attest to that. I had one done here just a couple months ago and I was in and out for sure within a half an hour. And if there are any questions about the pictures while they're being done, the tech will just say, okay, just sit right here. And then I didn't get a really clear picture. I'll just take another one a second. And so that's all done right while you're at your appointment. It was very fast.
Yes.
Did you want to add something else, Jay?
No, like I said, it's very, and two, our appointments are with this machine really it is very quick. And normally our days, you can get in, there's really no waiting. Pretty much you can be scheduled within a couple of days if your provider gives you the order.
Jay, I'd like to add something to your comments there too. One of the things that I found really rewarding as a provider is that we often get those results back the same day in the office too. So women aren't waiting around a long time worrying about their results. We at least get it within 24 hours, and which is awesome for a radiology department to have that kind of turnaround. So I think that's another great advantage of having the mammograms right here locally. We have great readings and the response time for turnaround is great.
Yeah, that was what we were finding even from patients going to other facilities, that they were having like a 1 to 2 months wait to get in for mammography. And in fact, we just had a patient come here yesterday that their provider was going to order the study to go to Beaumont Hospital, and it was 4 months wait before they could get a mammogram performed. And so they came here yesterday, and like I said, their provider had the report yesterday. So if that patient has anything going on at all, it's 4 months can really be a big change in their diagnosis and their treatment. Yeah.
Okay, I have a question here. And Suzette, you said that women should start getting mammograms around the age of 40. And this question is, how often should you get a mammogram after age 50? And it doesn't matter if you've always been clear.
Yeah, that's a great question, Joan. And as you may or may not be aware, there are about 6 organizations that put out guidelines for health, preventive health in particular. So it does depend on what guideline you're looking at. Some of the guidelines are yearly, from the age of 40 to 70. Some of them will start changing to every other year. Now, what I can tell you is that the median age for diagnosis for breast cancer is 62. And when you're talking about median age of 62, that means 50% of the patients were diagnosed under the age of 62, and 50% of them were diagnosed over the age of 62. So if your insurance will pay for yearly mammograms, I am in that camp that you should be getting them yearly. When you're 70, every other year is certainly acceptable for that. And we usually recommend stopping mammograms at about the age of 80. And that has to do with the longevity of patients living after the diagnosis of breast cancer. If you're 80 and diagnosed, you'll probably live about 10 years without any treatment. So and are you going to get aggressive treatment? Usually not. So we usually stop mammograms at the age of 80. So I recommend yearly from age 40 up.
Yes, so that I'd like to add too, like I heard the technologist, it was yesterday or day before, there was a patient that had missed like either 2 or 3 years since their last mammogram. And during that interval, there was a suspicious area that is quite prominent. And the radiologist suggested a biopsy of that area, and because it was very suspicious. But like they said, the patient had just missed either 2 or 3 years of mammograms, and now that area is really like very obvious. Yeah.
I'm going to ask a follow-up question, Jay, to you, because we have a question here about when would you need a biopsy? So since you were just talking about the woman with a biopsy, can you give us some parameters there?
The normal steps that the radiologists typically follow is if they see a suspicious area on the initial mammogram, the patient, a lot of times they'll have them come back for additional magnification views or just a little different angles, that on a mammogram site. And also they'll do an ultrasound of that area, because the ultrasound really helps them tell too if the lesion is more solid or maybe cystic, or if it has shadowing or not shadowing, and just there's other characteristics that will help them determine if it's guide them towards if it's suspicious for malignancy. So when they come back and have that diagnostic mammogram and the ultrasound, usually right at that point, the radiologist will know just from the appearance from these 2 additional studies whether that area should be biopsied. Occasionally, like I said, if there's still questioning whether or not that area should be biopsied, that's where the contrast and enhanced mammography will really come in. It's like Suzette said, the very first thing that a cancer does, even at a real early age, is establish blood flow so it can grow and feed itself. So that's where the contrast enhanced mammography, if that lesion that the doctor is looking at and it's suspicious under a diagnostic mam and ultrasound of the breast, if they do the contrast enhanced mammography and it highlights or enhances, I think it's like 98% sure that in that area is a malignancy. And then you really need the biopsy to determine what type of cancer cells is there and what stage and different things like that to determine your treatment. But that's the typical steps when something suspicious is seen, which guides the radiologist to suggest a biopsy or not.
Okay, thanks. And we have another question. This is from a woman who says, I have fibrocystic breasts or lumpy. Is the 3D machine better at telling the difference between the lumps and cancer?
Oh, definitely. That's where this is really the fibrous breast tissue is a big challenge, no matter if it's 2D or 3D. But the 3D is much better at it. It's got real thin layers or slices through that dense area, and so you could, where before on a 2D, that dense area you couldn't see through it. Where now it's those very thin slices through that area, and you can peel apart. Like if there's a real dense area that has like a small mass in there or small calcifications, it's the radiologists say it's a really 100% improvement, because then you can look right through that dense area. And also, again, that's where the contrast enhanced mammography, if there's a mass in one of those real dense areas, or a suspicion for a mass in one of those real dense areas, if that possible mass height enhances, which the dense tissue wouldn't enhance because it's normal tissue, then it really uncovers it, for the diagnosis.
Okay, great, thanks. Now we have a question about financial assistance. Is there financial assistance for those that are underinsured or no insurance? And maybe Steve or Suzette might know the answer to this question.
I'd love to throw that one at Suzette, but I'll take a shot at it.
Oh yeah.
Yeah, I know. Saved by
course
the
you
bell,
would.
right, Suzette? I was just texting Amy to find out, and we haven't seen any. Normally in October in the past, we've run, I don't want to call it a special, but we've been doing MAMs for $55. And that would be, I imagine, the screening MAM. And
Yeah.
other than that, we have normal financial assistance programs and policies that we have at McKenzie. So somebody who was either underinsured, uninsured, and needed some help would talk to our finance department. And we typically work those things out with the individuals. I think what's most important is that our primary interest at McKenzie is that we are managing the health of individuals. So having this test done is something that certainly we want to be able to do, and we want to be able to do it at the highest level, with the highest level of quality, which is why Jay's comments and Suzette's comments are important. I think your Beaumont example is classic. People thinking that they need to travel to the city to access better equipment or better imaging or just get this thing done by people that are really knowledgeable in this arena could not be further from the truth. The reality is that having this stuff done at a local level and having access to really the best imaging that is available, regardless of where you go in the state of Michigan, and we've had it here for a couple of years now, we're offering clearly state of the art, which I know is a cliche, but it's true. You can't get better imaging than you're getting right here at McKenzie. And what's even better yet is that we can move you through our program very quickly. So you're not going to have that 4-month, 4-week, or even 4-hour wait if you did come in. So there's, the benefits of that are really not fully understood and appreciated until you go someplace else and you become a number. And I think that's the difference. So not only are we able to move you through our system, we're able to access experts that can analyze the images that we get, and we can get you some answers and results pretty quickly. Suzette, I imagine you've been on the receiving end of getting results rapidly and being able to tell your patient what the results are, and how does that feel?
Oh, one, it's awesome to be able to get those results so quickly back and to be able to share with patients a negative result or a positive result. And hey, listen, we need to move quickly on this. We need to move forward. And here's what our plan is going to be. That there's nothing worse than having somebody waiting months for a result or to get a test and be worrying that whole time. And as Jay had mentioned earlier, cancer doesn't sit around and wait for the mammogram, right? So it's still growing. It's got its blood supply, it's getting its nutrients and its oxygen through the blood, and it continues to grow. So the sooner we can get that test done, if it's a screening or if I've palpated a mass in the clinic, the better outcome for all of us. We get to diagnose you sooner, we get to get you into treatment sooner, and you have a chance at cure and a long life.
And I think it's important to also point out, and I know Jay would do this, and you would as well, Suzette, when we have talked about not all 3D MAMs are created equal, and we talk about that because in fact, they're not. What Jay has described from a technological standpoint and from an artificial intelligence standpoint, this is remarkable stuff, and it really does get at those small, typically unidentifiable tumors or suspicious areas.
Yeah. Well, yeah, too, if I could add about Steve, is like when the hospital approved us to get the artificial intelligence software. The representative from the company pulled up to the hospital. They got out of their car and they said, they were awestruck. They said, they come in and they said, you guys are not our typical customer. I said, what do you mean? They go, well, typically anybody that has this artificial intelligence software are like the Henry Ford Health System, Beaumont, U of M. They just couldn't believe that they were so happy, that this type of software was going to even be offered to our patients in our area, But like I said, we're offering something that normally only the big facilities would have the capability to offer.
That really does show a commitment to our community, that have that ability to take care of our community this well. It's an awesome thing.
Oh, yes, because one thing to point out is, like I said, every hospital is required to have some type of computer-aided diagnostic overread of the mammography studies. So even if a facility has the very lowest cost computer-aided diagnosis program, McKenzie is offering the highest level computer-aided diagnosis program at no cost to the patient. So it does really prove a huge commitment.
Yes.
And Jay, are women taking advantage of this? Do you have quite a few patients using the mammography?
Oh, yes, our volume's gone up significantly right from the start, but even yearly now. That's what the technologists are telling me, we're seeing it even in the office daily. Our technologists, like when somebody comes here for a mammogram and they haven't had any previous studies here, we have to, call the other facilities and request those previous studies. And daily we're having 2 or 3 patients where we have to call and get their previous studies. Usually it's from the Port Huron area, and those patients are, like I said, so happy that before they were driving to Port Huron to have their studies. Now they can just come in, like I said, in a half hour and no drive, well, just into town, and then have their study performed. But yeah, but even patients had told us before when they called to get a mammogram scheduled, if we didn't, they said, as soon as you have 3D or we'll come there, and they definitely did. They are coming here.
That's great. Now, just to circle back I just want to be clear about financial assistance. If a woman feels like they do need some financial assistance, I think that there's a women's assistance fund maybe, but how would they find out about that, Steve or Jay or what?
Oh yeah. Or Steve, one thing too, yeah, we have, even this week, we've had 3 patients come in now already this week for the $55 mammograms. So the patient only pays the $55 cash out of their pocket, and then the rest is covered through that fund.
Oh, okay.
Yeah.
And Joan, I would add, if you're one of those shoppers, you'll probably find a better deal someplace, but is it really a better deal? Remember, not all MAMs are created equal. So the value component of what we're offering here is probably what I think most people should be focusing on, because you'll at least leave here comfortable knowing that what we've told you we've found is exactly what's there.
And so the women could either call Mackenzie, or should they talk to their primary care provider about their concern about cost, or what do you think? What would you recommend?
I think the conversation can begin with their primary care provider who is writing the order. Okay. And, our primaries have no problem calling finance and business office and seeing what we have available. And we're all interested in doing the same thing. How do we get this patient in here and out with some great results and do it at the least cost to them? And we work with people all the time because healthcare is expensive, and we recognize that.
I would echo Steve in that start with your primary care. If you're concerned that perhaps mammogram isn't part of your preventative care package, we do have some ability to look up insurances to see if that's true or not. And we also know who to contact over at the hospital to see if we can help that person out.
Okay, I've got a few more questions here. This one is for you, Suzette. Do I still need to do a self-exam?
Absolutely. So if you look at the randomized studies that have been done looking at breast cancer, the 2 things that have been proven to find cancer early is mammogram and self-exam. So yes, everybody should still continue with a self-exam.
And someone would like to know how to lower their risk of breast cancer.
Some things environmentally we know will increase people's risk for breast cancer, and one of those is obesity. So keeping our weight within a normal BMI will decrease our risk of breast cancer. Eating less processed foods will help decrease our risk of breast cancer. There is some research data on taking an aspirin a day decreases the risk of multiple cancers, breast and colon in particular. And exercise, a healthy lifestyle, stress reduction, all those things can help. Genes do play a role in it, although not as much as a lot of people think. Most patients that are diagnosed with breast cancer do not have a family history of it, although it certainly can be genetic. So live well, live healthy. Get your mammogram.
That's right. That's what we're here for.
Yeah.
And this question is for Jay. Thanks, Suzette.
Okay.
This is, maybe Suzette, either one. What is the difference in cancer stages? For instance, 0, 1, 2, 3. And can you detect cancer at the lower stages?
I can address about the detection. So that might have to, I'm not an expert at all on the stages, but yeah, definitely the detection. That is where, like I said, between the enhanced imaging and the enhanced artificial intelligence software, we have just from our experience now, and there's been like 4 millimeter masses picked up that, which is extremely tiny, and also those masses has been, that tiny, and then plus a lot of times they're back towards the chest wall, like by the rib area, and which makes it really difficult. And even the radiologists say those areas are the ones that they have the worst time in picking up abnormalities. So like I said, we've had now several instances where that artificial intelligence software said, "Hey, doctor, look at this," and they circle it, and then the radiologist like, "Oh my God," like I said, without that artificial intelligence software, that might not have been picked up until next year or maybe the following year, and then by that point, if it was a aggressive type of cancer, a year's difference could make a real big difference in the person's outcome.
Yes,
So
huge. When you're talking about staging cancers, it is very different, one from cancer to cancer, and also very different from cell type to cell type within the same cancer. So generally speaking, a stage 0 cancer is that there are very suspicious cells seen on a biopsy, but no distinct mass is seen. So it's called cancer in situ. Kind of there, kind of not, but definitely you needed to be doing something about it. A stage 1 pertains to the size. If breast cancer is less than 1 centimeter in size and there's no metastatic disease, no node involvement, it's considered a stage 1. Now, they'll need to know the cell type to know if that's a stage 1A or a stage 1B. But the treatment very well may be a lumpectomy with or without radiation therapy, and maybe chemotherapy, maybe hormone therapy, depending on if they're ER or PR positive or negative. That's their hormone status. And it goes from there where 2 is a larger tumor, 3 is a larger tumor with lymph nodes close to it. A stage 4 is out of the local area and it's considered metastatic disease. But there's a lot of different criteria in there, but getting a cancer early, hopefully you're in a stage 1 or 2 where we know we can cure that, is where we want to be. That's why we want to do prevention and early screening.
All right, thank you. Here, I don't know for sure if you addressed this, Suzette. How often does a woman need a mammogram?
Starting at the age of 40, there is going to be recommendations depending on what guidelines you're looking at, that should be yearly for the majority of women. Some women can go to every 2 years, and you really should discuss that option with your provider. But most of us still believe in that yearly mammogram.
So a mammogram might be part of their annual exam.
It should be
Right.
part of their annual exam,
Mhm.
correct. Should be discussed and scheduled at that time. And then, of course, if they're feeling something abnormal or they have concerns, we're happy to discuss it at any time. But yes, it needs to be addressed during that annual.
Okay. And this is kind of an easy question. How do I get an appointment? So if a woman does want a mammogram, does she need a doctor's order? How does that work? Anyone?
Yes, they call the registration department at the outpatient, and yes, they do need a doctor's order because so that also depending on what the report is, if it's just a normal negative report, then your doctor doesn't have to do anything special. But it depends on if there's findings, then you really need your provider, your primary care provider to kind of interpret the results. And then also if there's anything further treatment to be done, they will need to be the one ordering this. So yeah, you really need your provider to get you the order and then help you interpret what hopefully the study doesn't show anything, but if there is abnormal findings or suspicious findings, they will help you determine the next steps of your care.
Okay, great. And now, Steve, before, in fact, several of you talked about the fundraising efforts of the McKenzie Foundation. And if someone would want to donate to the McKenzie Foundation, Steve, how should they go about doing that or learning more about the foundation?
Well, Joan, first of all, I want to make sure everyone knows that you're the big cheese of our foundation.
Well, that's pretty awkward right there.
Yeah, okay. Joan is the chair over the foundation. We have a number of qualified individuals that chair the various committees, but certainly contacting Nina at McKenzie and going to our webpage should allow you to access the foundation and any information related to that. And if you have any questions or need more detail, there will be contact information there.
That's great. And we just got a question in for you, Steve. Have you noticed an increase in COVID-19 cases at the hospital?
We've not. I should say we had a few in the spring. And I think at that time everyone was highly sensitive to any sniffles they may have and whether or not it was COVID. So we would process those folks as quickly as possible. And we did have some positives that came out of that, but not very many, relatively speaking. We've not seen that rise anymore. I think people, for the most part, as I indicated in the front end of this, have been doing a great job of protecting themselves and at the same time, and in so doing, protecting others, which is what's most important. We're hoping that we don't see a rise in this, but we do expect that we're going to see a lot of people coming in who may have flu-like symptoms because it's just that time of year. And the instruments that we have here, we can collect a specimen, we can run it and get a result back in an hour unless there are others running already on those instruments. But what we can test for is not just COVID. We're testing for 22 other pathogens that you would typically see. So we're getting a broad view of, okay, you don't have COVID, but what else do you have? And then the emergency physician can go ahead and treat for that. So we're in good shape if you have any concerns. And the fact that we have negative pressure rooms, we can protect you and others from you by processing you in those rooms.
Okay. And here's one other question that just came in. Are there fewer mammograms being performed due to COVID?
Initially, like I said, when in this early spring there, yes. Not only mammograms, but every other study and all the volumes in our department went down significantly, and all across the United States. People just were hunkering down, not going anywhere, going to hospitals or anything. So, but after probably June, like our volumes pretty much went right back up to normal. And like I said, now they're above last year, because more patients are coming in than did last year at this time. So yeah, it's like the COVID initially had a big effect, but then people seeing that, we're taking precautions and they can come in and have these necessary preventative studies or any type study done and do it safely and not delay any treatment that might be needed for them, So, but yeah, we don't have any delays right now from COVID at all, because of the precautions.
That's great. So women are feeling comfortable and coming to the hospital and getting their preventative care done and visiting the primary care providers. People are secure, I think, in knowing that the providers are going to be taking every precaution that they can. The hospital is safe, that it's really important for people to get their exams done in a timely manner.
Yeah, Joan, I want to speak to that just briefly, but we're constantly in communication with other organizations, both large and small, not only throughout the state, regionally, but nationally. And what we keep hearing from large organizations in particular is that same sort of, you're kidding me. You guys have 4 negative pressure rooms in your organization. You guys are taking all of these measures to protect people. You guys are doing probably a better job than most of us are capable of doing, let alone are doing. So I think the local community particularly can rest assured that it won't be because we don't have policies and procedures in place if they come here to access care. We don't want people to put off necessary care or exams or anything for that matter, because that could lead to them becoming more ill, and that's exactly the opposite of what we're trying to achieve. The healthier you are, the better you're going to be able to combat anything. So feel comfortable coming here, and just be patient with the process that we run you through when you do enter the facility, because it's for your protection as well as everyone else's.
Yeah, that's really reassuring, Steve. Thanks a lot. I know I came in to do this town hall and I got my temp taken, and yeah, it was nothing. Plus, it was nice that I had a normal temp, and so I got that answered for myself too, which is good.
There you go.
As somebody just chatted in, thank you for being prepared and ready to assist us with the pandemic. This is from a person listening.
Well, great. We appreciate it. We take this stuff seriously, and we've invested a lot of time and effort to make sure that everybody is safe.
Absolutely. Well, I think my questions that I have here are answered. Does anyone have anything else they'd like to share? We're almost at the end of our time. We're all set?
I'd say from us, Joan, we really thank the foundation for right from the start. When Steve seen the price tag that we have to pay for this equipment, that's where he said, you're going to have to speak to the foundations. But that was the simple part, because once it gave the presentations to the foundation, it's like they were on board right from the start, saying, we have to have this here at McKenzie. You know, it was unbelievable, and we really appreciate this support.
Well, that's great. And, you know, I'm the chair of the foundation, but the foundation wouldn't be anything without its donors. And so people have just stepped up to the plate, and we're continuing to do that fundraising. There was an opportunity for the hospital to purchase the unit, this particular unit, and they were able to do that with the commitment that we made as a foundation to continue to seek donations for this really important equipment. And so the donors are, people have just been stepping up to the plate. We're so appreciative of that.
I know, right from the start, the very first meeting, the members there just said, okay, we have to have this equipment here. It's like that. There wasn't no more discussion. It was just that we have to have it. So that was great.
Well, good. Yeah, it's lovely to be a part of such a great project and such a great organization. It really is.
Yep.
So I'd like to thank our panelists for their time today, as well as each of you who have participated from wherever you are to learn about these important topics. The next town hall will be December 2nd. So please watch your email for future updates and other events and invitations. I do want to say that our What Your Mama Never Told You, I think that Steve initiated that. Oh, and there's Suzette. Suzette is one of our presenters at What Your Mama Never Told You. And it's on November 12th at 7 p.m. It's going to be virtual this year, but it's going to be on Zoom. But during that process, you'll be able to ask questions anonymously. And Suzette and Brady Tripkowski and Nicole Beagle from CMH are going to be our panelists. And if you were at one of these events last year, you will know that they are a really good time, and we will make it work through Zoom. And if you will know that some people enjoyed having a glass of wine while they ask these questions, and you're welcome to do that at home too. We want this to be informal. We want it to be fun. And we want you to really feel comfortable in asking any single question. And I'm telling you, we got a lot of questions. At the one I was at in Port St. Luc, yeah, a lot of questions, no holds barred. So we want you to remember about that. And I think that's it. That concludes today's webinar, unless someone else has something to say. And we want to thank you again for joining us. And we'll see you in December and hopefully November 12th for the women. Bye-bye.